My name is Thomas Aloia, and I'm the VP and Director of Oncology Services at Ascension Health. I've been a longtime SAGES member and a bit of a retired MIS surgeon now. But two good things about going to the dark side of administration is you don't have to wear a tie, you get to present some insight, I think, to surgeons about administration that maybe they don't realize. So I have no disclosures. I think the first thing to talk about is just this cognitive dissonance when we all see, know, feel, and are certain that ERAS is better for the hospital, for the balance sheet of the hospital, for our patients, for our providers. When we approach administration and say, we should do ERAS, it's really revolutionizing all parts of surgical care. And I like to tell people, I think ERAS is the most important surgical innovation since monitoring. The hospital administration says, show me the money, right? So let's talk about that. So we're going to talk about the quid pro quo of these interactions and managing the counterintuition that we feel with administration. We'll hopefully take the dreaded out of the business case, look at levers for ERAS financial return and some take-home points. So I'll try to cruise through this in about 4 minutes. The first thing is this isn't binary. You know, asking for ERAS support should not be transactional, and I think this is where the problem starts. So what are the providers going to give in a transactional approach to administration? They're going to give their expertise or their blood, their time or their sweat, and their enthusiasm or their tears. So we're going to give blood, sweat, and tears. We think we're going to offer a lowering of the length of stay. And we know we're going to have less complication rates, that's very clear. And we're going to lower readmission rates, and we kind of roll all that up to say that there's clearly going to be revenue generation. But it's actually quite indirect, and it's not direct. Higher patient satisfaction, we hope to throw that into the mix and get some credit for that. What we ask for typically is money for an ERAS coordinator, a data manager, a data analyst, and probably some educational material for developmental support. So we're going to give this is what we're asking for, and what we get from administration is golf claps. And there's a couple reasons for that, but it can be really concerning and off-putting. You know, we can propose this, get rejected, and say, how can they possibly not invest in this? This is clearly a better way to care for people. We need just a modicum of investment. But this is what the administration thinks about that. You haven't shown me any direct dollars. You think you've shown me direct dollars, but you've shown me indirect dollars, and I'll get into that. The administrator thinks I have no control. I'm going to give you $2 million. It's out the door. I have no role in it, and I have no control. And frankly, this is QI. As a provider, you should be striving for better outcomes at baseline without any incentives or extra financial support. So how can we do this better? Make it more circular and incremental in its benefits. When we say lower length of stay, what we're really saying is we've given you an increased volume opportunity, and administrators want to see growth, which means very directly more cases done in the OR per year. If you can show them a growth opportunity, they see the dollar signs. And we have to have sensitivity analyses to demonstrate that this is not an on-off switch, but the more they invest, the better we'll do. The more they invest, the more sustainable it will be. What we need to add to our ask, coordinator, data manager, et cetera, educational materials, and a long-term collaboration with administration, where they invest, we return. They invest more, we return more. So this usually gets engagement and support, and the key is to state that the degree of improvement in revenue, patient satisfaction, whatever, scales to how much the administration puts into it. Give them a modicum of control over this. So now they see this, number one, as a growth opportunity, more cases in the OR. This is a standardization lever. The administration loves it when they can make the doctors standardize something. I control the degree to which this is successful. Give them a modicum of control, and this is a dynamic relationship. That's a totally different proposition to propose to them. So some of you have seen this. I think we've all been through this. I don't actually think this is true, but we all know that you have this initial enthusiasm for ERAS, and then you get a reality check. There's some ineptitude, and then everybody thinks over time it'll just organically get better, lift off, and go to the stratosphere. That's not actually how things work. So if you do not have an initial investment and you do this off blood, sweat, and tears, and I think we've all been there, this is what happens. Initial enthusiasm, a little bit of cratering, and then you basically plateau. You know, you kind of truck along, 40% of the people are doing it, a new group of residents comes in, it falls apart, you know, you just kind of level like that. If you put in a minimal investment at the very beginning, what you see is you may start slower, but over time you're going to win and you're going to have a program that sustains and goes on and grows. And we proved this. So we got a $2 million grant in the University of Texas system, and we gave $75,000 a year to 5 different institutions from the beginning of their ERAS program, and every single one of them basically tripled the number of programs that were doing ERAS within their hospitals and are sustainable. This is probably going to project super small, but I have some bullets around it. This is a spreadsheet that you need to fill in to make this happen. Again, it's too small probably to see, but some bullets are going to come up here. So you need to put in your length of stay change opportunity. So are you saying you're going to change length of stay by half a day, 1 day, 2 days? What are you proposing? Because that affects the model. You have to put in your complication rate change, because on the far left side, if you can read it, what it says is that for a case without complications, you have a margin of about $2,000. For a case with complications, you have zero margin on that case for the hospital. So if you factor in a complication rate change, you actually move more people from the 0 to the 2,000 column. You should factor in your readmission rate change and show them where the dollars are there. But the most important thing is you have to have a good program to accomplish any of those things. So you have to have a fundamental program, and there's lots of talks on that. In terms of ERAS buy-in from providers, so this is very important. If you say 25% of my providers are going to do it, you're going to have a very minimal financial return. If 75% of them do it, you'll have a much larger return. And this is one of the most important ones, bed utilization. So can you add procedures to newly filled open beds? If you cannot add procedures to newly filled open beds, you're unlikely to affect the financial gains. This is a little model just to show you. The black line here is the margin per day post-op. So almost all the money floats up in the first day when you have OR charges versus OR costs. And basically, you bleed every day after that. So you start taking money away from margin. If you discharge, you're probably left with a baby margin at the end of this. If you don't discharge and you have a complication, you erase that margin, because basically the costs go up higher than the revenues with a complication. So this is where it's very important to look at that last day. For the sake of time, I'm going to cruise through this. These are the sensitivity analyses, and what these show you is that the ROI is not dependent on the length of stay decrease, but on your ability to put new patients into those beds that you've opened up with shorter length of stay. And this goes on the range of negative return all the way out to $4 million positive in this scenario. which you can see in the slides. The other thing to know is that your ROI has to be 4 times the salary and benefits of the personnel you want to hire. So if you want to hire a nurse for $120,000, you have to have 4x that to get it through administration. And this is the scale based on how much provider buy-in there is. This is a huge component that you can bring to the table depending on what % provider buy-in there is. So to quickly summarize, getting to yes, make it a shared commitment to continuous improvement, but that alone will be assumed and not rewarded with investment. Understand the motivators, power, control, the ability to shut something down if it's not going well on the administrative side. Propose a collaboration, not a transaction. Link provider buy-in and standardization to administrative support. That's really at the heart of the quid pro quo. Short-term growth is a leading intangible indicator. Again, if you can't show more case growth, you're not going to be financially sustainable. The FTE asks have to be supported by 4x ROI. And do your sensitivity analyses. It shows you can walk in administration shoes, give all parties their best and worst case so risk can be calibrated. It clarifies the levers of success and demonstrates that success depends on the scale of shared commitment. So thanks very much, and we'll bring up our next speaker.